Hello, everyone, and welcome to the Parkinson's Foundation's Wellness Wednesday webinar. Thank you for joining us today. Please know that we will be recording today's presentation, and you will get a follow-up email from us with a link to today's recording and additional resources in about a week. Thank you so much for being here. Welcome to today's Wellness Wednesday program. PD Health at Home is presented by the Light of Day Foundation, whose generosity has made today's programming possible. Before we get into it, I wanted to remind you about our other PD Health at Home virtual programs. Each week, we offer sessions tailored to support people with Parkinson's and their care partners, including Mindfulness Mondays, Wellness Wednesdays, Fitness Fridays, and expert briefings. We also have our Spanish language series, EP Salud en Casa. Be sure to visit our website to see what's coming up and explore our archived videos on YouTube. You can learn more about our upcoming virtual programs and register at parkinson.org/pdhealth. Looking at who's registered for today's program, I did want to share a few specific resources for those of you who are newly diagnosed and for those who are supporting someone living with Parkinson's. The Parkinson's Foundation offers guidance, emotional support, and resources to help you and your loved ones navigate the diagnosis. For some, a Parkinson's disease diagnosis comes as a relief, an explanation for something that was previously unexplained. For others, it might be more stunning, struggling with what the future may look like. As you begin to process your emotions, which can be wide-ranging, it's important to know that you are not alone. Get connected to essential resources by visiting our newly diagnosed webpage, and you'll find the website on the screen over here. And for those of you who are supporting someone with Parkinson's, it's important to know that the foundation has a space for you too. Whether you're new to caregiving or have years of experience, this dedicated webpage meets you where you are at, with practical tools, educational content, and emotional support. You'll find principal guides, videos, and tips to navigate the evolving role of caregiving. It also connects you to programs like the Care Partner Summit, our PD Health at Home, mindfulness and education sessions, and relevant episodes from our podcasts. For those planning ahead, we offer trusted tools like the Hospital Safety Guide for advanced care planning guidance and legal considerations. Please bookmark or share this page with others. It's a comprehensive starting point and a trusted place to return to as needs change. Welcome to today's Coffee and Conversation series. These subjects were chosen based on your continuous feedback through our surveys and through questions submitted during these live programs. After today, we'll have 2 more sessions to wrap up the year. So be sure to stay connected with our virtual education programs by visiting parkinson.org/pdhealth. So today we return to our Coffee and Conversation series with today's topic on breaking the ice on taboo topics. Living with Parkinson's comes with challenges that can feel awkward or uncomfortable to discuss, yet they deeply affect everyday life. Today, we'll explore why these issues can be difficult to talk about, how they impact emotional and social well-being, and practical ways to address them with care partners, friends, and healthcare professionals. As we move into this conversation, please grab your coffee, tea, or your beverage of choice. Feel free to share your questions about topics that often go unspoken. Intimacy, incontinence, drooling, constipation, whatever that may be. You can also submit your questions anonymously if you'd like. So we'll use the time today to answer as many questions as we can get to. I'd like to introduce the Parkinson's Foundation's Chief Medical Officer and Associate Professor of Neurology at Duke University, Dr. Sneha Mantri. Joining Dr. Mantri is Allison Allen, a licensed clinical social worker for over 10 years, and the Center of Excellence Coordinator at the Duke Movement Disorder Center. Her work has focused on understanding what really matters the most to people living with Parkinson's and supporting them as they navigate new diagnoses, life, work, and care for their families. As a clinical social worker, she has a particular interest in non-motor and mental health symptoms experienced by people living with Parkinson's. So, Dr. Mantri, I'll pass it over to you first to open our conversation by first talking about what exactly do we mean when we say something is taboo.
Yeah, thank you, Danielle. And thank you all for being here as part of this conversation. I think it's a really critically important topic because taboo topics can be really hard sometimes to get into. So I'm really glad that we have this hour together to talk through what does taboo mean, what does stigma look like in Parkinson's, and how can people with Parkinson's disease, their care partners, their loved ones, and people around them help advocate for their needs, particularly around sensitive or difficult conversations. So when we think about taboo topics in Parkinson's disease, it's really a wide variety of potential symptoms or concerns or thoughts about the future that can be embarrassing or stigmatized or just difficult to bring up with family members or loved ones, friends, or sometimes even your care team. It can be difficult to sort of broach these topics. Some examples of things that we might be talking about today would include intimacy and sexual relationships, or relationship changes in general, with the changes that are brought by Parkinson's and how that affects partnerships and family dynamics. Constipation and urinary incontinence, really common in Parkinson's, but sometimes really hard to talk about, especially if your care team doesn't sort of proactively bring it up, and how to broach those topics. We have a whole conversation next time in August, sort of dedicated to psychosis and hallucinations, but we'll be touching on that a little bit today because sometimes hallucinations can happen for people with Parkinson's, and it can be really scary to experience and sometimes scary to admit that you're experiencing them to others. People can have a lot of different types of worries and fears about their future and what to expect. And in particular, certain medication-related side effects, drooling, for instance, or something called impulse control disorder or impulse control behaviors, compulsions that are sometimes related, not necessarily to Parkinson's itself, but to the medications that we use to treat it. And so, we'll hopefully over the next, 50 minutes or so, have an opportunity to delve into each of these in a little bit more detail, take some questions from you all, and talk about what you can do to help, again, advocate for yourself and your loved ones around these potentially sensitive issues.
Thank you so much, Dr. Mantri. And with that, I'll welcome back Allison Allen and my colleague Adolfo Diaz from the helpline team. Adolfo is Vice President of our Information and Resources, which means he leads our helpline specialists, amazing team over here at the foundation. So let's get Adolfo back on camera, and then I'll leave it off to our experts to lead us in today's conversation.
Thank you, Danielle. Dr. Mantri, one of the questions that came up during a registration, we have several that have been submitted, and we encourage the viewers today to please submit your questions in the chat. We'll try to get to as many of those as possible. When we think about taboo Parkinson's symptoms, which ones do you feel or have you seen from your experience in the clinic have the greatest impact in terms of the person's quality of life, their relationships? Is there one or more others, or maybe one that is like absolutely like this one no one wants to talk about or is the worst?
Yeah, no, it's a great question. And I think, just like Parkinson's shows up differently in different people, the taboo symptoms or the difficult, sensitive symptoms show up differently in different people. I would say that probably some of the most common symptoms that people experience are constipation, sleep changes, incontinence can be a really difficult one, both to experience, it's unfortunately quite common, and then to bring up and say, I'm having urinary incontinence or fecal incontinence. But it's important to do so, to bring it up to your care team, because there's a lot of things that we can do, either medication changes, new medicines, non-medication options that can help to address these, big quality of life issues. I think the other one that I often hear from patients, for instance, is drooling, or like excessive saliva. Sometimes that can be because of the Parkinson's itself. Sometimes it's because of the medicines that we use to treat Parkinson's symptoms. And so it's helpful to kind of think through that. And it's a really targeted treatment for that drooling if it starts to become more bothersome or keeps people from speaking appropriately or engaging in social activities because they're embarrassed by it. There's a very, very effective and quick treatment. A couple of shots right here in the parotid glands in the cheeks, and it takes care of it for several months. So, you know, one of these things that people might not even realize is related to their Parkinson's, but if I ask about it or if they bring it up proactively, we've got a treatment that we can do right then and there to help address it. So that's just one example. I mean, I think, you know, Allison, you've certainly seen a number of other things, especially around relationships and the way that some of these symptoms can affect the care partners as well.
Yeah, absolutely. First of all, to say thank you for creating this dedicated space for this, because I think that we are sort of leading by example here, in creating this space and wanting these opportunities to discuss tough things more freely, with each other, with our provider, with our care team as well. So I think this is a really good example. But just like you said in the beginning, I mean, what the things that have the greatest impact really vary and they're super unique. But overall, as a whole, those things get more and more kind of control when they go unaddressed, right? Sometimes you hear this kind of uh, comically simple phrase like name it to tame it, right? But if we're not talking about it, if we're not bringing it up, it's going to get more control, and possibly we would miss an opportunity to address and actually, manage or change a symptom like she mentioned with the saliva. So I would definitely say that if you're feeling a little unsure about something or uncomfortable, we're all human. Your care team is also human. So there's a chance that that door might not be opened from your provider also, right? And so if the door's not open for you, it can be harder to go through it. So recognize that your care team are human too, but don't be afraid to bring it up is my first and foremost thing.
It's interesting the topic of constipation because Dr. Montres, you said it's very common that people don't make that connection or that association or even think about some of the other GI issues with dehydration and things that also kind of all come together. In fact, on the helpline, we get about at least 4 to 5 calls a week on a weekly basis that are specifically where the main topic focus was people calling precisely about constipation. But I'm wondering if, given the different dynamics in the clinical setting and how people approach when they're going to their appointments, are there topics that that someone is more likely to disclose or discuss with you, Dr. Montri, versus Alice and you as a social worker? Some things that maybe they feel more comfortable with one type of professional versus another one, and what should people do?
Yeah.
Um,
Do you want to take that,
Yeah,
Allison?
sure. I mean, we are fortunate that we work with a team of folks, right? Which is just more opportunities to connect and build rapport. So I would encourage you, if your OT feels like a safe space for you and you're seeing them more often, bring it up to your OT. They can help you identify who the right person is or share with the team if you do have that situation. Dr. Mantri mentioned before, and I kind of missed that part of the question, but about how these things affect relationships. Certainly, something like constipation can really take control of your social life in your day, right? And we get really worried um, when folks start staying home and missing out on the things that they, really look for. So a conversation with the social worker may lead to something about isolation or people staying home when really the conversation is also about constipation, for example. So sometimes we're coming at it, at different angles, or we're seeing different outcomes caused by the same tough topic, I guess.
Yeah, and I would also add that, Allison and I are very fortunate that we've been working together for a number of years in the Duke interdisciplinary clinic. And so we really have this opportunity as a team to sit down once a week and talk through different issues that patients may have brought up. For instance, did they say something to the social worker, but it might be better addressed or more easily addressed with physical therapy or vice versa? And so that sort of format and that model, I think, does allow for a little bit more open conversation, especially as patients sort of go through that interdisciplinary rotation and meet all these folks and get to see how people work well together. I know a number of other centers also have interdisciplinary teams, and sometimes even if the interdisciplinary team is not physically located in the same place, which they may not be, just being able to bring it up to one person and say, hey, can you pass this on to the rest of my team, my care team, can be a really powerful way of making sure that the question gets to the right type of clinician, so that it can get addressed.
Yeah, I find that a lot of times folks just aren't sure who to bring it up to. I will also say that we really encourage family members and care partners to come to visits with our folks with Parkinson's. But if you're an adult child coming with your mom or dad who has Parkinson's, challenges with intimacy might not be the most comfortable situation. So definitely for any providers that are out there, keep in mind that we can also bring opportunities to invite this and, always offer a follow-up conversation later as well.
Okay, excellent. So speaking of the topic of care partners and family members participating, as you mentioned, if you have adult children, which interestingly is an increasing demographic that we're seeing more and more in terms of individuals who reach out through our helpline, much more important demographic. But in that challenge of what they're going to, kind of feel comfortable sharing. In general, particularly around the topic, Allison, you brought up about intimacy. We hear this a lot on Helpline, where there is that difficulty about not knowing where to bring it up. How do folks in the clinic for you navigate? Like, how common is it for someone to bring up issues about intimacies and sexuality challenges as a result of the disease? Or is that something that, Allison, as you said, you have to prompt or almost kind of open the door so people feel comfortable?
Yeah, I think that open the door metaphor, actually, we were just talking about that earlier today. It really can be challenging, I think, for patients and care partners to bring up, for a variety of reasons. Whether it's the dynamic of an adult child who's the care partner to a parent with Parkinson's, or even between spouses or partners. The changes with Parkinson's itself, whether it's erectile dysfunction, changes in libido, changes with aging that might not be related to Parkinson's at all, but are certainly, affecting the relationship between partners, can make it hard to sort of bring up. I would say that often, at least the way that I approach intimacy conversations or potential intimacy issues between partners is to start by just asking, what has your relationship been like? And relationship can mean a lot of different things, right? It can look a lot of different ways. And then if I get a sense that physical intimacy might be a big challenge or a big concern for either of the partners, I'll try to probe a little bit more. Sometimes I'll refer to our social work team or sex therapist team, family therapist team, can be really helpful at helping people kind of navigate these changes.
Are there any like checklists or sort of standard questions that you throw out there in terms of like for probe to kind of tease that out? Or
Yeah, there are standardized questionnaires like the non-motor symptoms questionnaire, that can be filled out. That one actually is nice because it doesn't even technically require the clinician to ask the questions directly. The patient or family member can sort of fill it out ahead of time, or think through those symptoms ahead of time to say, hey, what are the things that we really want to talk about in this visit? So that tends to be the sort of thing, if you're looking for like a standardized way of approaching it. My own typical approach in the clinic tends to be more personalized than standardized, I would say. And so it really is about trying to read the room as much as possible and trying to leave the door open for concerns or questions that, you know, maybe I didn't have on my agenda when I walked in the room, but I can see that the patient or family or care partner, whoever's there with them, really needs to talk about.
Yeah, and shout out to the Parkinson's Foundation for having, resources of all types on any of these topics, right? So if you are listening in right now and have something that you're not sure who to go to or you're not sure about bringing it up, I definitely would encourage you just to type in, intimacy or anything like that into the library feature. And you may find a live conversation coming up about it soon. And perhaps participating or reading would help you to share your concerns or find the right words. Sometimes it's just kind of putting our own feelings into words so that you can bring it up. There's a lot out there on intimacy. And I think centers overall, as well as the foundation, are starting to, and support groups, by the way, community groups, are starting to create dedicated spaces where we're naming in advance, hey, we're going to have a conversation about intimacy. It gives time, or, any topic, but it gives folks a time to prepare, to think about who they want to go to the group with, right? Do I want to go to my partner with this one, or do I want to go with my mom or dad to this group? And you just get some time to think it through. So the more that we see those safe spaces, I think it's just going to make all of these things kind of easier to talk about as a community.
Yeah, and thank you, Allison, for calling out the foundation resources. And besides the print and materials that are online, webinars, podcasts, of course, I'll make a plug for my own team on the helpline, where that does provide an opportunity. The 1-800-4PD-INFO, the 473-4636. You can call anonymously and speak with a Parkinson's disease information specialist. And I do feel that sometimes. We do get calls where obviously individuals, family members are not comfortable speaking with their healthcare professional, and hopefully, my team can help guide folks in terms of sort of the path, not only learning for themselves, but also how to broach it with their healthcare professional. And again, it can be totally anonymous. So I think that's kind of helpful, and maybe takes a little bit of the lowers a little bit of the any kind of embarrassment or stigma factors. It also makes me think, and we hear this also, that the oftentimes from healthcare consumer perspective, they may feel that the healthcare professional may not be comfortable talking about this, and they've kind of, because we hear this too, they've kind of like tried to mention something, but it's like, okay, next. What are your thoughts on that, Dr. Mantri, in terms of your colleagues and comfort level, and Allison yourself too, with broaching some of these topics?
Yeah, I mean, I think it's a very fair point, right? Like everybody's human and everybody has a different sort of comfort level and threshold level of what they're willing to talk about or able to talk about. Um, so I think it is a little bit of trying to suss that out in the moment. Again, like sort of opening the door a little bit and seeing how the other person responds. Like, is the care team, whoever that provider is, are they interested? Are they willing to talk about it? And if not, maybe they're not the right person to bring it up to, or to help with that particular condition for whatever reason. It might be out of their scope of practice. It might be something that they personally feel uncomfortable with, and so they have a hard time talking about it with patients. I think that's one of the reasons why it is so helpful to have multiple people on your care team. A primary care physician, a neurologist, a movement specialist, a social worker, an occupational therapist, because hopefully out of that group of people, there will be one person that is open to talking with you about it. And then again, if it's not within their direct scope, they can at least be the liaison to get you to somebody who is and is able to help you directly with it, with treatment, for instance.
So, what practical strategies, coping mechanisms, or kind of tools would you um, suggest for someone, just even if we just take some of the non-motor symptoms, particularly as we mentioned, constipation, drooling, particular seem to be a lot, more common ones. You mentioned about the injections possibly for drooling, but other more practical or maybe easy, more accessible things that someone might try.
Yeah, sure. So for drooling, the injections are very, very effective, but you have to have them done by somebody who knows what they're injecting and what they're doing and everything. So that may not be immediately accessible to a lot of people. The other thing that we sometimes recommend that people can do in the moment is get a hard candy or a peppermint or something like that and just suck on it, because what that does is help cue the swallowing reflex so that you're swallowing the excess saliva. Even if you can't sort of dry out your mouth, you can remind yourself unconsciously to swallow. Obviously, if you're doing that, you want to make sure that your swallowing function is in good order, because the last thing you want is for that peppermint to go down your windpipe by mistake. So I would not recommend that for somebody who's already having some trouble swallowing. But perhaps if you're not having swallowing issues, that's a really sort of immediate, effective, and pretty discreet intervention, right? Hard candy or a piece of gum or peppermint is something that many people might use, and it's not obvious to others what you're doing. And then there are also prescription medicines that can help to dry out the mouth a little bit. I'm always a little bit cautious with some of those prescription medicines because of the side effect profile of them. I hate the idea of starting a medicine to deal with a problem and then having to start a different medicine to deal with the side effects of the first medicine, and then you end up on a medicine treadmill. So they're effective, but you want to talk always with your care team directly about what to expect, what the risks are, and try to make that balancing act for yourself, because it is a very personalized sort of approach.
One of our viewers commenting on the issue, or something that they try to actually have almost a scarf or a napkin in hand, just kind of some subtle ways of being able to sort of manage, especially drooling is problematic. They're
Yeah.
sharing with us.
I think
Um,
sometimes folks may be experiencing something Dr. Mantri just mentioned, and your comment, Adolfo, reminds me is sometimes folks are having a little bit of an issue and or maybe it is a big issue, but they're not sure when to bring it up. Like when does it earn space in my, in my twice a year visit, or something like that. And I think no matter the topic or the symptom, I think that if you're starting to notice it's impacting your quality of life, that you're missing out on the things you enjoy with drooling, with constipation, things like that. Again, we often hear folks are changing their social habits, right? They're missing, their kids' sports games or family gatherings, or, perhaps going to a religious service or something like that. And that usually tells the team that there's something going on that maybe we need to address. So if you have something that maybe doesn't feel like it should be a big deal, but it's really impacting you on a day-to-day, you know, in your day-to-day life, and that you're missing out on things, that to me says that is the time to bring it up. That is the time to bring it up. So no matter the things, no matter the topic, I hope that helps if there's anyone listening.
Dr. Mantri, and there's a request here to elaborate a little bit more on the connection between swallowing, because this is another thing that sometimes individuals may not make the connection, and drooling. Uh,
Mm.
so I think it's sort of an important distinction to make, or sort of the relationship between one or the other.
Yeah, for sure. Because, drooling can be caused by one of two things. And honestly, it's sometimes a combination of both. One is that you start producing excess saliva from the parotid glands. That's what some of the medications or the injections, for instance, are intended to reduce, just kind of by dropping the salivary production. So drooling can be caused by that. You have hypersalivation, so we treat it by trying to reduce that salivation. But the other thing that can cause drooling is with Parkinson's, as folks know, a lot of the automatic things that you've been doing your whole life without thinking about start to have to become more conscious, and you have to remember to do them. And one of those functions for some people is swallowing. All of us are producing saliva all the time, and we're sort of unconsciously, automatically, without thinking about it, swallowing throughout the day and swallowing that saliva. But with Parkinson's, you have to remember to swallow. And so that's what some of the tricks, like the hard candy or a piece of gum or something like that, is just that sort of reminder in your mouth to swallow on a regular basis. It can be, again, kind of for most people, I suspect drooling is really a combination of both. For some, it's some degree of excess saliva and it's some degree of reduced swallowing. So if we can attack it on both fronts, if you will, we can sometimes get a little bit better control. And then, as Allison said, get people able to do the things that they want to do in their life, whether that's going to a game or going to a concert or going to church or a religious service or whatever it is, without feeling the embarrassment of having to have a scarf or a napkin in their mouth, at all times.
And follow-up question on that is a question about excess mucus. And is that the same as the excess, as the salivation, or is it one and the same, or are we talking two different things here?
Yeah, it's technically two different things because it's two different types of glands that produce it, and two different sort of types of bodily fluid. I mean, that said, the swallowing issue, the forgetting to swallow issue, is common to both of those. So I think, that's part of it's, as they say, it's the same but different in some ways.
Yeah, and certainly the role of physical, excuse me, speech therapy,
Mhm.
obviously would be key on this. Oftentimes we hear from care partners on the helpline will be describing or commenting about their loved one's voice getting very low. We will often hear like, well, they weren't a big talker, they never talked very loud. We always try to stress to encourage people to identify the fact that it's like, well, because I've literally had one gentleman one time say like, I'm up in years, I've talked all I needed to talk, I'm done. Nobody needs to hear me, and it's like, well, not making the connection, the importance about volume of voice, the fact that it's the swallowing that you should be concerned about. The actual volume is, obviously can affect communication, quality of life in that regard, but the real thing you need to be worried about. So, a call out for obviously raising the importance as you've described, and Allison mentioned, of bringing it up to anybody on the team, whatever the topic may be, that can help point and guide you. And again, when in doubt, you can contact the helpline and they'll try to help you um, tease that out as well. So shifting gears a little bit, and kind of, as I feel like we're kind of going along the GI track here, but coming back to we're coming from the mouth to thinking about the whole issue around constipation, and similarly bladder and bowel, which is a big thing, as you said, very embarrassing. Um, there's a request here for, other recommendations between some of the, drink more water and fiber. What else can someone do around this issue that is so prevalent of constipation in Parkinson's?
Yeah, it's probably one of the most common non-motor symptoms of Parkinson's. And for many people, constipation can start many, many years before any other like physical symptoms start to develop. And constipation can get worse over time, partly because people are often drinking less. As you said, people are exercising less sometimes with Parkinson's. We know that movement of the body helps to move things along in the GI tract as well. But there are some, medications certainly that can help with constipation. Things like Miralax, which is available over the counter. There are prescription medicines that can be prescribed by your primary care or your Parkinson specialist or a GI specialist if you're seeing a GI doc. There's also different types of devices, for lack of a better word. I'm smiling a little bit here because I don't know if the occupational therapist who works in our interdisciplinary clinic at Duke is on this call. But shout out to Melissa if she is. She taught me about something called the squatty potty, which is a little device that people can put in their bathroom that helps to sort of elevate the legs and knees when you're sitting on the commode, because that position with your knees kind of higher up makes it a lot easier to use the restroom. And it's something that, again, I, as a movement disorders doctor, I never learned that in medical school or in residency or in fellowship. I learned it from, Melissa, our occupational therapist. So I think, again, that's one of the reasons why having multiple people on your care team can be so helpful, because the answer, if you will, might come from somewhere that you really don't expect it to.
Great. Great. Thank you. Let's see, we have additional questions coming in. So shifting gears to intimacy and erectile dysfunction. So we have a question from one of our viewers saying, how does Parkinson's erectile affect erectile dysfunction? Is it just a matter of a muscle movement, motor symptoms, or are there other things that involve?
Yeah, from a medical perspective, erectile dysfunction in Parkinson's is often caused by changes in blood flow, or like where blood flows, if you will. Just like people with Parkinson's can get lightheaded when they stand up, that's a blood pressure, a blood flow issue. Similarly, they can have trouble with erectile dysfunction just from lack of blood flow into the penis to cause an erection. And again, there are medicines, there are treatments that can help with that. Usually those medicines are prescribed and managed by a urologist rather than a neurologist. But if you bring it up to your movement disorders doctor or your general neurologist who's helping you with your Parkinson's, or your primary care doctor, they should be able to hopefully get you a referral to urology. But I think the other part of erectile dysfunction or intimacy or sexual issues in Parkinson's itself that doesn't get talked about as much as the medical side of things is sometimes the relationship side of things. Allison, I don't know if you want to weigh in on some of those changes that can happen between partners as Parkinson's progresses.
Oh, absolutely. Um, this bucket of symptoms we're talking about, the non-motor symptoms and how they affect our relationships. I mean, the research tells us loud and clear that these are the ones that really impact quality of life, even more than a tremor, for example, overall, when we look at the data, right? So this is absolutely one of them. And relationships are impacted in so many different ways. And we may hear about it, any of us on the team may hear about it in a different way, right? Usually, a lot of times it's coming from a place of goodness and wanting to help one partner. If we're talking about a romantic relationship or people that live in a house together, one partner may start slowly taking over responsibilities around the house or something like that. And then that can be interpreted in all kinds of different ways by the person with Parkinson's, who, when really that person is just trying to help, right? And then those things kind of stay with us day and night, right? And kind of come into our intimate relationships, which are sexual and not and when we say intimacy, we mean, sexual relationships as well as just those other close partnerships. I think communication, open and honest communication at thoughtful times, at strategic times throughout the day and throughout the weeks can really go far when discussing intimacy in particular, or just other sensitive topics, right? We all know this, but we have to I have to remind myself this. But it's not a great time after a big argument or when you're feeling very heated about something, or stressed about something. That maybe is not the best time. So if you are trying to come up with a good way to have a tough conversation with a loved one, I would actually really recommend, and we do this often, recommend letting them know in advance. Say, there's something on my mind, and you can say what it is or not. And I would like to find a good time to talk to you about this. When would be a good time to talk, right? And what would be a good location? What would be a neutral location? And sometimes having just like we talked about, having this dedicated space in our community, finding dedicated time with your loved one with Parkinson's, if you're a care partner, and if you're a person with Parkinson's, to talk to your family and those people that mean the most to you. That can go a long way when we're talking about difficult topics. Um, Sometimes communication and Parkinson's, another taboo topic we haven't come up with, but is really impacted by apathy and our facial masking. And there can be various levels of insight from the person with Parkinson's about how they experience that symptom. But for the people that love somebody with Parkinson's, um, apathy and facial masking can be, if they don't know that it's caused by Parkinson's, or even they do, it can sometimes be misinterpreted as a lack of interest or, um, that something doesn't matter as much to them. And so that's also an important one that we need to talk about. And then as partners and as family members, we need to be aware of, hey, apathy is a part of this interaction, right? Facial masking is a part of this interaction. And that's where that really clear communication, verbal communication, makes a difference as well. Kind of off on a tangent on that, but there's lots of different ways that relationships, are impacted.
And for someone who doesn't, there's another question that's come up from our viewers, someone who doesn't have access to sort of counseling or a sex therapist in their area, what resources or how would they even go about finding the right professional to speak to? Um,
Well, unfortunately, these are highly sought after folks, and there's not a lot, right? We live in a resource rich area near a center of excellence, and we don't have a sex therapist to refer to. I know that there are some centers that are really fortunate to have that person. Definitely reach out to, a social worker. They can help you find use the right keywords to search. When we are looking for counseling, keep in mind we can be looking for a clinical social worker, a psychologist, a licensed counselor. So there's lots of different professionals that might be doing this work, and they may have different professional backgrounds. Um, and with virtual options for counseling now, that really does kind of open up some doors for all of us. And I know that the Parkinson's Foundation does have a couple of great recordings and podcasts from some of those folks that are living in the Parkinson specific space, but it is rare to find somebody who is a sex therapist and an expert in Parkinson's. We have some treasures in our community, and everybody works together to make sure that those resources are sort of as widely available as they can be. But definitely check with your team to see if maybe um, if maybe there's a different name or different type of professional you should be looking for. We didn't mention the pelvic floor PT earlier, kind of in those conversations, but often pelvic floor PTs can be a really great resource for a lot of these issues that we've talked about um, as well.
Yeah, for sure. Pelvic floor PT is great for, sexual issues, incontinence, urinary incontinence, fecal incontinence, constipation, like anything related to the pelvis and pelvic floor, they are just the absolute experts on.
For men and
but
women.
Yeah.
that was my question that I was going to ask, because I think a lot of times when you hear pelvic floor physical therapy, there's automatically that default reaction that, oh, that's just for women only.
Mhm.
So that's a good distinction to make about the availability of that. So another interesting question that we have here that's come up is regarding how do you go about broaching these very sort of personal issues, things like sex, with a professional who perhaps either doesn't speak your language or might even be a different age, different race, different gender. Um, do you see differences in between the way men or women may or may not be open for either of you to bring up these subjects?
That's a good question. I mean, I think a lot of it, a lot of all of these topics, but maybe particularly sexual issues, are very culturally driven, right? And everybody, I would say, probably has some baggage around that, both patients, care partners, romantic partners, clinicians. And so it can be harder to bring this up with somebody who sort of doesn't look like you or sound like you or is in the same age bracket as you. I completely understand that, but I also want to emphasize that these types of topics are often things that, unfortunately, unless the person with Parkinson's or their care partner is proactively bringing it up, it's unfortunately unlikely that the clinician will bring it up of their own accord in a visit for a couple of reasons. The biggest one is probably just the time pressure, because there's so many other things that we want to talk about in the visit. And we don't get to this. And then the other thing is that some people unfortunately are not comfortable talking about this because they feel like, oh, it's not my responsibility, or it's not my job, or I don't know how to address this, and so I don't know how to help. And so it does often fall back on the person with Parkinson's or their care partner, to help find those resources and to be their own advocate in that way, right? Like through with the help of the helpline and the resources on the Parkinson's Foundation website, as well as support groups, can be really, really helpful at helping people sort of navigate those conversations.
Yeah, I love that question that you said earlier when you asked folks, like, what has your relationship been like? And so, if anybody listening is kind of looking for some words to bring it up, you could, maybe reverse that, right? Like, our relationship is like this now, and it used to be like this before. And I'm experiencing that as a loss or a change that I want to talk about. Um, I want to add something to the intimacy and sexual relationship conversation that hasn't come up that is high on my list as a social worker for a taboo topic is impulse control behaviors. So in Parkinson's, we see these for all kinds of different reasons. I can let Dr. Mantri comment on that. But it's really important to know that this is something that happens in Parkinson's as a person living with Parkinson's or a care partner. And for whatever reason, we see a couple of big buckets: excessive spending, gambling or shopping, and also changes in our sexual behavior sometimes that are kind of outside of the norm of our relationships or how we've interacted with our partner before. And so that is something that really can impact folks and be really hard to bring up. So I like to mention that whenever we're having conversations like this, so that you can know that if you are experiencing a change like that, um, that it could be related to Parkinson's. And if you're on the skull, it probably is related to Parkinson's. And to bring that up. And I do think as a whole, providers, interdisciplinary providers overall, are getting better about asking that, but they may not ask it every time. Or maybe we don't have a good appreciation for what your baseline was. And so something may not stand out so much. We all get Amazon boxes every day, right? Probably during this call, I've gotten some. And so the shopping one is a little bit easier to hide now than it used to be. But if you're experiencing a change like that, um, like I said, increased spending, risky spending, gambling, or again, changes in sexual behavior that could even be risky, that could impact your health and your safety. It's definitely something to bring up. And if you're a care partner, remember you can always give information to your team, right? We may not be able to tell you about our patient, but we can receive your concerns as well.
Thank you for bringing that up, Allison. That's a great point. As you can imagine, we have our share of horror stories that we've heard about from family members, and including a few months ago, where someone who happened to see actually a podcast from the foundation, or listen to a podcast, and then this was the first that they realized that this was what was probably going on with their spouse. Uh, and they had just never heard that. They weren't even aware that this was a possibility, and were on class of medications that can sometimes trigger
Mhm.
some of these things. So yeah, it's very, very important to bring these up. So we have some folks watching who are interested in knowing about, in continuing the topic of intimacy, what they can do now. Some, we may not have access to a therapist, but rather today, now, Allison, especially, I guess I would direct this to you. What questions or habits would help partners who are losing intimacy due to the PD? I guess they're asking, like, how do I bring this up with my loved one? And I guess it could be from either side, either the person with Parkinson's or the care partner, their spouse, and are there different changes in sexual activities or the way they express intimacy that, how do they do that in the absence of having access to, as you said, to a very limited resource as it is right now?
Yeah, great questions. So intimacy is very personal, right? And it really varies. So I think one thing to do is kind of put away other people's norms aside, but do think about what is meaningful to you and what has been meaningful in your relationship, particularly if we're talking about sexual intimacy. So the first piece of advice I would say is kind of going back to something we already talked about a bit, is I wouldn't expect to catch your person who you love off guard in the kitchen while they're doing the dishes and have a big conversation right then and there. I would kind of give like a warning. Warning sounds negative, but I would say there's something that I would like to talk about, right? And kind of plan some time, whatever works best for you. If you say I want to talk on Tuesday at 4, you just kind of let the person know, whatever's normal in your relationship of how you address tough topics. But maybe also you haven't had to do it like this before. So I get that this may sound kind of weird and formulated, but I would definitely let the person know you want to have a conversation and don't expect that you're going to have that conversation, in that moment, um, as well. Um, also, recognize that this is something we often experience these changes as loss, right? And kind of naming that there's a grieving process and loss. And I think sometimes if we think about these type of changes in that context, it can help us wrap our head around it. That doesn't mean we don't have intimacy anymore, right? At all, if something has been changed. And sometimes it can help to recognize, let's just say, if we're talking about intercourse specifically, sometimes it helps us to recognize other meaningful or intimate interactions that can go a long way in your relationship. And so together you could name those, right? I like holding hands, or I like snuggling at night, or whatever that may be, and make time and space for that. So I think opening the door to sort of thinking creatively about meaningful interactions for you. I also think, and different people may have different opinions on this, but I do think having that conversation together before you as a if we're talking about a romantic couple, not the best idea to kind of be in your doctor's office and for one of you to bring it up at the first time. I think if that's the situation, I'd have that conversation together at home and say, I think we should get some support. And so let's bring this up at our appointment. Certainly if you're by yourself, that's kind of a different thing. Um, for care partners who may not have access to, a provider right in front of them, without their or for their own issues, I would definitely recommend checking out care partner support groups. We have them at Duke. Many centers have them. The Parkinson's Foundation has great care partner events as well. And a lot of the time these days, you will see that there is dedicated space on intimacy. So you can get some creative ideas there for what's worked for other folks as well.
Dr. Mantri or Allison, tips that you might offer folks on knowing when things might be progressing, or as it was stated here, when the disease might be getting worse? Are there feelings or warnings that people should feel that say, like, okay, there's a change, something's happening here?
Yeah, it's a great question because it can sometimes be hard to know what is day-to-day variation and what is like a longer term or a more significant change in the disease as a whole. I think taking time to like keep a log or a diary or track symptoms can sometimes be helpful there. Um, but by conversely, you don't want to get so into the weeds of tracking things hour by hour or minute by minute that you sort of lose that bigger picture. So it's a tough balance sometimes. One of the things that can sometimes be a little bit of a, wake up call, for lack of a better word, that things might be changing or progressing, is, something that used to be able to do easily is now more difficult, or in some cases avoiding it entirely because it's become so difficult. So just an example off the top of my head, that's not a very taboo example, but it's the first thing that came to me. Cooking and chopping vegetables or something like that. It's something that many of us do on a regular basis throughout our, teen and adult life. But that can get more and more challenging for Parkinson's. And so if you notice that, you're not cooking as much as you used to, and you're now, more just getting microwave meals and eating that might be an indicator that, hey, there's something that I need to talk with my care team about, that my disease is impacting my life in a different way. Allison, I don't know if you have other ideas or thoughts.
Yeah, Parkinson's is interesting because, and you bring up a really good example, right? Sometimes of cooking, but sometimes very early on in our experience with Parkinson's, we may have trouble putting on our shirt, right? But then we can go to work and do our job just fine, right? So it's kind of like sometimes some of these simpler, um, not cooking is not necessarily simple, but it's actually a lot of multitasking going on there just to plan the meal and then to cook and then plan for the rest of the week, right? And sometimes we actually don't appreciate all the steps that come into
Mhm.
meal planning and buying the right food and cooking. So that is actually a really good example of a multi-step executive functioning thing that would show a change. But back to what I was saying, sometimes in Parkinson's, there's rather simple things that seem like a big deal, but they may happen early on in our disease course. And so that can throw folks off or be scary. Um, absolutely. Um, when I'm thinking of it from the perspective of like a taboo topic, right? Having trouble addressing disease progression with a loved one, I certainly can really appreciate this question. I also appreciate that everybody on this call is human, and so sometimes it really helps us to know. Oh, I want to know a stage. We hear that a lot. Certain people really want to know where are they. They want to know compared to how they were doing last year or something like that. If you're a person who really craves that feedback, I think I would encourage you to feel empowered to tell your provider team, I want to know how I'm doing compared, or maybe I don't want to know, right? Um, and um, I think putting our thoughts down, we won't have time to talk much about like advanced care planning, but I think thinking about what we want in the future can help us to get to feel a little bit better. These things are scary and they're unexpected, but we do can kind of give ourselves that gift of thinking through what things might, how we might want things to look as we do progress, and I think that can help it just a little bit.
Excellent. So one of our viewers is writing too and saying, they see a number of professionals, and they do feel, especially with some of these topics, as was mentioned, sometimes perhaps because of the discomfort on the professional themselves, there might just be a prescription or there might be kind of a quick referral and they'll like drop it. We don't have to talk about this. So they asked a very interesting question as they said, how do I set up such a team? How that can be responsive to my needs? They were saying just a little communication would be helpful. But it doesn't always seem to happen. Is there anything that, as a consumer, and this is something on the helpline we try to educate folks who call in, that hey, you go to the mechanic, take your car to get repaired. You don't, there's a certain level of service that you're expecting, and if not, you say something about it. You don't remain quiet. I think with healthcare, sometimes we have this sort of kind of like I'm receiving, and it's important for people to advocate for themselves. So, is there anything that you would suggest that is helpful for yourselves as providers that consumers of the healthcare system can say, can bring, can do? I know, Dr. Mantri, you mentioned about tracking symptoms and not going crazy about that also either, but is there anything else that you can think of that would help sort of facilitate that communication or to check in?
Yeah, it can be a huge, huge challenge, especially if people are not the clinicians. I mean, if the clinicians are not located in the same physical space or even in the same health system where when we can communicate either face to face or, through secure messaging within the computer system and we can see each other's notes. I think that does often help with communication. But if you're in a situation where that's not the way that your care team is set up, where you've got one person over here and one person over here, and you feel like you kind of have to be the quarterback and do all the coordination yourself. That's a huge burden to take on. I do think that if people have a care partner, or multiple care partners even, to help share that burden, that can be really helpful. The other thing that some of my patients have done that I have found very helpful as a clinician, especially when I'm meeting somebody for the first time, is if they have like a binder or a timeline or a list of like, here's what's happened to me over the last, few years, or here are my top current concerns that I need to address, or here are my goals for the next year or so, so that that can help me in making recommendations about what to do. So those sorts of things can be really helpful. The foundation actually has something like this, a worksheet that we really encourage people to look at and to use. Either bring it physically to your appointments, or at least take the time to work through it on your own ahead of time. At the Optimizing Care Initiative is a really, really useful tool that can help both with symptom tracking, but especially in clarifying, like, what are the top concerns that I want to make sure are addressed. And then you can take that sheet to multiple people and make sure that everybody, or as many people as possible, are on the same page about what's going on.
Yeah, I really love that, like advocate encouraging folks to say what is meaningful to them, right? Like to say what their goals are, and and maybe it says constipation is a problem, and that would be meaningful. But maybe it says, I want to be able to walk on my greenway, for example, like I used to do, or something like that. And understanding what is meaningful to our patients and their families will help us to collaborate with y'all better.
Yeah. Well, thank you very much, Dr. Mantri and Allison, and we'll hand it back to Danielle to close us out.
Amazing. I really appreciate the three of you just really going over so many different topics, so many different symptoms that our Parkinson's community has clearly been sharing that it's been difficult for them to talk about. We went over so many resources, so many different symptoms. We will include links to all of these things that we discussed today in the follow-up email, including the worksheet, including the link to our helpline. So please just keep a lookout for that follow-up email that will include a whole lot of resources from what we discussed today. So thank you again, Dr. Mantri. Thank you, Allison. Thank you, Adolfo, for offering your knowledge and time for today's Wellness Wednesday. Thank you, everyone today who joined us for the webinar. Thank you to the Light of Day Foundation, whose generosity has made PD Health at Home possible. And then I will just put another plug here for our helpline. If we didn't get to your question, or if maybe there's a new one that comes up, please know that we're here to help. The Parkinson's Foundation helpline is here to support you. It's staffed by nurses, social workers, and Parkinson's specialists. It's where you can go to help answer whatever questions you may have about Parkinson's disease. You can learn more about them by visiting parkinson.org/helpline, and you have the phone number as well as an email address here on the screen for you. Before we wrap up, please do take the time to fill out the evaluation survey. That's how we're able to figure out what topics you are most interested in, so that we can get experts like who we had today to help answer those questions that you have. Thank you again for joining us today. We're so honored to be able to share this time with you, and we do hope that you found the information today helpful. Please know that you're not alone. We are here to support you every step of the way. So thank you again, and we hope to see you next time.